All right, unmuted. Thank you, Jeremy, and thank you for elevating me to the senior ranks of professor. I appreciate that for the day, not actually the case. And so, yeah, I was asked to speak on the topic of what's new in Staph bacteremia, and much of what is new is available or is going to be available soon in publications. So, in keeping with this as an educational session, I'm also going to be talking a little bit about trial design and statistics, which I think is often neglected and where there have been some significant advances in this particular field. So before I can say what's new in Staph bacteremia, I have to say what's old. And I'm just going to spend a couple of slides going through the probably multiple thousands of years, but in reality, 140 years from the discovery of Staph aureus in 1880 through to about 2022, 2023, which is what's old. So the bacteria was discovered 145 years ago, and it had a very high mortality. It was known to occur post surgery and postpartum for similar reasons. Penicillin was introduced in around about 1940s, a slightly American slide, and then resistance was detected 10 years later. Methicillin was introduced, and 2 years later, methicillin resistance was reported in 1961. And then MRSA, particularly in America, became endemic in the 1980s. And by the 1990s, they had community-acquired MRSA with Pantone, Valentine, leukocidin positive MRSA. Vancomycin resistance emerged. And still around 2020 was still stuck on something like 15 to 30% mortality. I can tell you from the cohort at Helen Joseph for the last 2 years, I won't bore you with the epidemiology of the whole thing, but it's a common illness. There have been about 190 cases just at Helen Joseph in the last 24 months. And 25% of those people died before the blood culture was even positive. So the mortality rate starts at 25% prior to even being seen by ID and often prior to getting any kind of definitive antibiotics. So that's the kind of situation that we're in. And if I can make this go away. And so just to summarize, there really weren't any RCTs worth mentioning prior to 2006. There were some, they were small. They weren't very well necessarily blinded, and it didn't really tell us very much. So we'll start in terms of trials in 2006. And the first really high quality trial was Vance Fowler's daptomycin trial, which was the registration trial published in New England Journal of Medicine, showing that daptomycin could replace a beta-lactam in MSSA or vancomycin in MRSA, and daptomycin was non-inferior, and then it was therefore registered for Staph bacteremia, including right-sided endocarditis. They've then followed a number of trials, and they have one thing in common, which they're essentially all adding an extra therapy, trying to reduce mortality by adding an extra therapy to your background therapy, either adding a beta-lactam and MRSA in Canberra, adding rifampicin in Arrest, adding fosfomycin, or daptomycin. And if you look on the right, universally, these have shown no benefit. So that's sort of 20 years worth of 15 years worth of trials showing that whatever you add to your baseline doesn't seem to make any difference. And you'll see this slide again later, but this is approximately the number of patients who've been randomized in that time, just under 4,000. Sounds like not a bad number. Typically a single randomization per participant. So you're looking at about 3,800 randomizations in that time. And the summary really of this period of studying Staph bacteremia in terms of the drugs that we're going to use is that daptomycin is an alternative to vancomycin or beta-lactams in SAB. And that can include right-sided endocarditis. And that essentially adjunctive therapies don't work. We've tried several in MRSA and MSSA. None have shown benefit, and essentially all have increased adverse events. So that takes us up to just a very, very important point, because I'm not just going to be discussing drugs and Randomized trials, although that is the mainstay of what I want to present. Staph something that emerged in this time period, which is very important, is that infectious disease consultation for Staph bacteremia improves outcome. Now, it doesn't seem that we needed a trial to tell us that someone with a heart attack needed to see a cardiologist, but apparently we do need that to show that an infectious disease specialist improves the outcome of someone with an infection. But I guess we just have to play dumb and do that. And so this meta-analysis looked at nearly 5,000 patients in 17 studies. It's observational, with all the caveats that come with that, but it did suggest a reduction in. I mean, you might expect that only the sicker patients get referred to ID, rather than the other way around. So you might think it was sort of biased against the ID physician observationally, but it's hard to know. But there was a clear reduction in 30 and 90-day mortality, and improvement in all the facets of SAB care, which is not really the focus of this talk. They suggested, this is in 2016, that a cluster randomized trial or trials were needed to confirm these findings. I'm not sure anyone is doing that or is planning to do that. Like I said, we don't require that from our other specialists to show that they have an impact on the people that they look after. So let's just bear that in mind. Okay, so let's just go back. I think we can do polls. I think if someone can do polls. So let's just go back to end of 2022, because some of you will know the data I'm about to present. You've got a 23-year-old man with his signs of intravenous drug use and a sepsis syndrome. His blood culture is positive for Staph aureus sensitive. The cefoxime disc is sensitive. I'll move this to the side, I think. How would you treat this man in 2022, 2023? You've got cefazolin, an anti-staphylococcal penicillin, flucloxaclox, cefazolin and rifampicin, an anti-staphylococcal penicillin, rifampicin, or daptomycin. Going up and down.
They can't see it as it comes. You can, but so just shout.
Oh, they can't see it. Okay, they're still going up and down. Do I do then? Do I do end poll and then we?
Yeah, I can do.
Or I'll just tell you. I'll just tell you. Yeah. So overwhelmingly, well, I mean, there's no consensus, which I'm pleased about. 47% say cefazolin, 39% an anti-staphylococcal penicillin, 9% said cefazolin plus rifampicin, and then small numbers for the others. So what I wanted to show you was what was published in that time, about the time that you would have been answering that question, was a survey done by, and the same names crop up wherever you look in Staph bacteremia, Lance Fowler here as a senior author. We were involved in this. I don't know how many of you were involved, but I was involved, where the authors sent surveys around different continents, pretty much every continent that has a hospital on it, and asked people questions about how they manage Staph bacteremia. And this shows the results of what people's first choice antibiotic was for MSSA bacteremia. And you can see wide variation. In America, cefazolin was preferred by most, but not all. In Europe, it's the opposite. Australia is like Europe. It's kind of even in South America. Essentially, it's all over the show. That people were just using whatever they felt like. This is just, I'm going to give you another couple of results just to show you how all over the place things are. People were asked in what percentage of their Staph bacteremia patients they made an oral switch. And in America, overwhelmingly very unlikely, but still some people did it frequently, 8%. And then kind of all over the place again, most frequently in Africa, you had a oral switch, but the message is people were doing completely different things depending where they were, even though this is a reasonably homogeneous illness. Even definitions, this is what people considered. You might think that you know the definition of positive blood culture because you've been taught that, but actually there is no absolutely defined definition of a persistently positive blood culture. In America, it tended to be 3 to 4 days. In Europe, maybe 2 days. Again, kind of all over the place. So the point was that just what we kind of knew about Staph bacteremia was ID consults work, daptomycin can replace vancomycin or an anti-staphylococcal penicillin, but we didn't know much else, and people all around the world were doing completely different things. So this is ripe for study. And so before you do a study, you need a question. These were some of the important questions that they suggested at the end of the study, and we'll be able to answer a couple of them as we go through. The first is the most basic question: what is the first-line antibiotic in MSSA? An unknown answer, people doing different things. What should the duration of treatment be? I haven't shown data on that, but it's only from observational data. This idea that there's a minimum of 2 weeks has not ever been tested in a randomized controlled trial, and it's possible that 7 days is adequate for some patients. When is it safe to switch to oral antibiotics? Again, it's been studied in things like osteomyelitis and endocarditis, but not in Staph bacteremia per se. And the question we probably already answered, which should we be adding a second antibiotic? So the trials that I'm going to show you this slide again later, but just for comparison, from that sort of 2005-06 until 2022, we had randomized 4,000. Oh, I told you this already, didn't I? 4,000 patients. And then in the last 2 years, we've done incredibly well. We have, in just 2 short years, have now randomized over 4,500 patients. And we have 7,000 randomizations because participant patients have been randomized to more than one thing in the same trial. So this represents essentially a tripling of randomizations in 2 years compared to the whole of history before now, which is quite extraordinary. And that's really the basis of the trials that I'm going to show you today, the results that have been published or are peri-publication in this last 2 years. So the first question we got to, and I'm doing this in a slightly chronological order, not it's slightly out of sync, but largely chronological order. The first question that was asked is a switch to oral antibiotics safe and effective? A very reasonable question because we've had these big trials, like I said, in osteomyelitis and endocarditis, showing the safety. And this is the study that was published in 2024 by Akim Kash, who ran this trial out of Germany, called it Sabata, and he wanted to know the efficacy and safety of an early oral switch in low-risk Staph aureus bacteremia infection, an open-label non-inferiority RCT. And so essentially what he wanted to do was give people a week of IV therapy and then randomize them to continue IV therapy or switch to oral. They were 18-year-old or older SAB patients who'd had 5 to 7 days of IV therapy and had cleared the bacteria. And he had significant exclusion criteria, anything suggesting complicated Staph aureus bacteremia, which we can discuss. There are a number of things, obviously including persistent bacteremia, any foreign device that couldn't be removed, and any severe comorbidity. So these patients really had to be very well and have a really very much of the easier end of Staph bacteremia to treat. Managed to get 213 patients in, evenly divided between oral switch and the standard of care. And his primary outcome was the occurrence of any complication related to Staph bacteremia within 90 days. And he had 13 in one group and 12 in the other, with a risk difference of 0.7, which met his non-inferiority margin. If you can see my pointer, the non-inferiority margin was, if this number was less than -10, then it was considered non-inferior. And he gave a p-value of 0.013. I want you just to keep that in your mind because I'm going to come back to it when we start talking about statistics. And the safety events were similar. So he concluded that oral switch antimicrobial therapy was non-inferior to intravenous therapy in low-risk Staph patients. But what you need to read through the article itself to see how difficult this was. They screened to get their 200 and something patients. They screened over 5,000 cases, and almost all of them met some or didn't meet an inclusion criteria or met an exclusion criteria. And so, whilst he's probably shown that in a very small subgroup of patients, it's safe to switch to oral, the impact on care is relatively limited, given the exclusion criteria. So if you don't mind, I'm going to just move a little bit into trial design, because this is not the sort of thing that gets taught very often, certainly not in medical schools. I'm going to take the risk of using an analogy, take the risk of using football. So the trials that we've seen, particularly Sabato that I just showed you, and these other adjunctive trials and the daptomycin trial, all use a similar approach to answering important clinical questions. And the way they do that, the analogy in football would be that you want to have a game between side A and side B. In some cases, you screen lots and lots of players to find those 11, 21, 22 players. You build a stadium from scratch at vast expense. You play a game between the two teams. You might get a draw. You're not sure who's better. Team A, team B might win. And then you dismantle the stadium, publish your results, and go home. That's essentially what that trial that Akim Kash did. It was very expensive, took a long time to do. It was actually stopped because recruitment was so slow. And all the trial apparatus was dismantled at the end, and back to square one with a small answer. A much better way, and this brings me to the SNAP trial, which is kind of the centerpiece of this discussion because we've been involved in it, takes a different approach. And rather than a head-to-head trial, it's called an adaptive platform approach. And I'll go into this in a bit more detail, but the analogy is that rather than building a stadium and then dismantling it after one game, we build a stadium, a big stadium, expensive one, but we play multiple games in that stadium. We play, A against B, and then the winner plays C against D, etc. And when we get to an answer, we close that question, and we may just keep going forward, keep moving to the right. There may not be a champion. You may just continue funding permitting to answer more and more questions. And this is considered by many people to be a much more efficient way of running a trial. I certainly think it's the future of infectious disease trials, probably other trials as well. We have funding to do one in PCP pneumonia in HIV and non-HIV patients, for example, using a very similar methodology, and certainly the way forward, I think, in terms of TB trials. How does this work? I'll run you through how SNAP works. So I'll explain this in a little bit of detail. So you have what are called silos and domains. Now, the silos are in the purple down the left. The silo is the resistance pattern of the staph. PSSA is penicillin sensitive, so fully sensitive. MSSA is penicillin resistant but methicillin sensitive, standard MSSA. And I'll explain why those two are not lumped together in a minute. And then MRSA. And so your participant will be in one of those three. And then they can be in any of the domains. Once they're in their silo, they can be in any, all, at least one of the domains, but they don't have to be in all of them. So there's in green, antibiotic backbone, and you can see in the top one, it's cloxacillin versus penicillin. And in MRSA, it's an addition of vancomycin, of cefazolin to vancomycin. And so each has a backbone domain. And then, in fact, regardless of what silo you're in, you can enter the other domains. An adjunctive domain is clindamycin or no clindamycin. And then there are oral switch domains, and there's even a PET-CT domain. And the way it works is that you identify a patient and take consent, and then you can immediately randomize them into the clindamycin arm, because it doesn't matter what this. All you need to know is that it's Staph aureus. You don't need to know any of the detailed sensitivities. When you get some sensitivities, you can then randomize them to the antibiotic domain. And then the way the computer system works is that all the randomizations are done, but are sealed. in a sort of proxy envelope. And then at day 7, if your participant meets the criteria for equipoise at day 7, then you open the randomization and they either go IV or oral. If they were not eligible at day 7, you can see if they're eligible at day 14. People who are going to require obviously significantly more than 14 days antibiotics. And similarly, there we're not involved, but there's a PET CT domain. So essentially, you can be in all, or there's no point being in it if you're not in one domain, but everyone can be in the clindamycin, no clindamycin domain. And then you can be in whichever domains are considered appropriate by the investigator. They kept the primary outcome very straightforward, all-cause mortality at 90 days. Very simple, relatively easy to ascertain. Some important secondary outcomes: mortality up to 90 days, microbiological failure, and C. diff diarrhea, because you could be causing harm. And then there were some domain-specific outcomes, particularly acute kidney injury in the antibiotic backbone and hepatotoxicity. So that's the study began in 2022. I'll tell you just now how far it's progressed. I'm going to make a slight segue into now, if I may, before I tell you more about the stuff, because this is where the divergence comes. If I was in the room, I would ask you to tell me who these people are. I don't know if people can type in who they are. Who's the person? Anyone know the person on the left? Hard. I'm looking at the chat. Oh, well done, Jeremy. And the person on the right, I'm sure this is a bit easier. Yeah, Jeremy again. Thomas Bayes. So we talk about frequentist statistics and Bayesian statistics. I don't think if he was alive today, Ronald Fisher would be a frequentist statistician particularly, but he did essentially invent what he invented, importantly, apart from Fisher's exact test, which you probably know, is the p-value. And we're going to be talking a little bit about p-values and a little bit about Bayesian statistics and how the world is changing from Fisher's, not really Fisher's view of the world, because Fisher's currently turning in his grave every time someone quotes a p-value, but how the world has moved towards Thomas Bayes' approach. So I'd like to do a quiz. Now, I told you to just pay a little bit of attention to the p-value in the Sabato trial. Actually, this question, the answer to this question is kind of irrelevant what the top part says, but in the Sabato trial, the p-value for non-inferiority was 0.013. I think we can all agree that that means there's a 1.3% probability of something. The null, don't get too hung up on the null hypothesis, but in this case, the null hypothesis was that the intervention is 10% worse than the control. But the answer to this A, B, C, D, E would be the same if the null hypothesis was that A was better than B or B was better than C. So what is there a 1.3% probability of? The null hypothesis being true. The null hypothesis is false. Of obtaining a result as or more extreme than the observed one, assuming the null hypothesis is true. Of the observed result occurring due to chance alone, and incorrect conclusions if the same test was repeated many times. God, we're getting on. Okay, just let that run a little bit more. Okay, 60 people, 63. Okay, it's still going up. So I think that's kind of settled now. We've got option A, 22%, option B, 16%, option C, 22%, option D, 33%, option E, 6%. So, monkeys at typewriters would get 20% for each. And these are all relatively close to 20 Only 63 people participated out of 219. That's interesting. I'm going to give you the answer. Do you think we could just run this again? Okay, 63 people answered. Now I'm just interested in your level of confidence. This is a multiple choice question test where you get 1 point if you're right, but you get -1 point if you're wrong. So you have to be really sure. Who would like to? Now you only answer if you're sure. See what results we get. Thank you. People are answering. That's interesting. Expecting people not to answer, given that they will get things wrong. They will lose marks if they're wrong. Okay, 45 people. Similar number of people. Yeah, quite a lot of people have answered. That's quite interesting. So people are pretty confident. Assuming it's the same people, are pretty confident that they know the answer here. Sort of settled at about 53. So only 10 people didn't answer. The results are relatively similar. 42% are convinced that D is correct. And then it's A is 11%, B 15%, C 28%, and then E 4%. So we've got, generally people think it's D, and they're pretty confident that they know the answer, even if they didn't think it was D. They're pretty confident. Okay, that's interesting. Okay, I'll give you the answer just now. I've not asked that question before. So this will give you the answer. This is from a paper which I hope you can read at the bottom, is well worth reading. Goliger, I think you say it, et al. In the Lancet in 2024. For anyone who's got any interest in this, this concept of Bayesian versus frequency statistics, and they presented using a pretend trial, made-up trial, 208. But the answer would be the same regardless of what trial you did. 280 participants randomly assigned to an intervention or control. The mortality in the control was 38%, and in the intervention it was 29%. The point estimate for the odds ratio of mortality was 0.66. And this is what the frequentist or Fisherian, not really, the p-value illustration looks like. So the curved line is created before you've done the study. Curved line, so it centers on 1, and the odds ratio of 1, that's no effect. This is the line, this is the graph you would get if you took 280 participants and there was no difference between the intervention and control. So think of it as a fair coin, a heads and tails coin that's completely fair. If you spun it 280 times to determine if you get more heads than tails, most commonly you would get an odds ratio of 1 and no effect. But occasionally, due to chance alone, you would get, due to chance alone, you would get slightly more heads, but it wouldn't happen that often, or slightly more tails, but it wouldn't happen that often, and it tends towards 0. But this is the same study done many, many times. What results would you get if there were no difference between intervention and control, or you've got a fair coin centered around 1? The result is the blue dashed line at 0.66. That's the result. It's a single point estimate in a straight line. And the p-value is the area to the left of that that's shaded. So the p-value is people think it's very intuitive. It's a highly non-intuitive statistic. It's actually on the assumption that the null hypothesis is true, i.e. there's a fair coin or no difference between intervention and control. What is the shaded area? That is the probability of getting a more extreme result, the same result, 0.66, or a more extreme result. That's the p-value. They don't give you the exact p-value here, but you can see it would be roughly 5%. So that's what it means, and that's all it means. It just means, and if we go to our answers, it can't tell you, because it's based on the null hypothesis being true, that is, no effect. It can't tell you anything about the null hypothesis. It doesn't tell you it's true. It doesn't tell you it's false. It doesn't tell you the chance that the probability that it occurred by chance, D. what it tells you is C, the probability of attaining a result as or more extreme than the observed one, assuming the null hypothesis is true. The problem with this is it's very non-intuitive, and people desperately want it to mean things that it doesn't mean. And it's become ubiquitous in medicine. When people want it to mean D or A or B, but it simply doesn't. And Fisher, bless him, is kind of turning in his grave. He knew exactly what this meant, and he was one of the people, probably the person who coined the phrase significant, statistically significant. And he chose this 5% value a little bit arbitrarily to mean significant. And what he meant by significant was that you should take notice of this result because it's relatively unlikely if the null hypothesis is true, and that you should do more testing. And that's really all he meant. He didn't mean it was important. He didn't mean the effect was large. He didn't mean that it meant anything necessarily meant anything to patients. He just meant that, oh, that's interesting. I think we should repeat that study and see where we go. So thanks for that. The first time I've done that p-value question before. But I don't blame anyone for getting it wrong. It's not taught in medical schools as far as I'm aware. And there's this continual cycle in the medical literature of somebody publishing a trial with a p-value and it getting over-interpreted. It's typically highly over-interpreted. And then another group of statisticians writing a paper explaining what the p-value means. And then everyone forgets that and they go back to the beginning. And we have another paper with a p-value. So the point is not to overvalue it. So what about Bayesian statistics? What can they tell you? Can they tell you something a little bit more intuitive? So the statistical approach to SNAP is called, and I'm not going to pretend that I can explain the details of this to you, a Bayesian hierarchical logistic regression model. And I'll explain what minimally informative priors mean. And there's a scheduled analysis every 500 patients. What they're looking for, you can see that in these different boxes that we saw earlier, that they're looking for non-inferiority. And if you get non-inferiority, you get superiority. This is when you're sort of comparing penicillin with cloxacillin. In the MRSA, where you're adding something, adding the cefazolin, you want to see superiority. In the clindamycin, again, you're adding something, you want to see superiority. And in oral switch, you're taking something away. Essentially, you are taking away the IV therapy for oral therapy, which has other benefits. And so you're looking for non-inferiority. So how does this work? So this is from that same paper. This is how the Bayesian statistics works. So they've got the same curves and the same lines here, but they mean completely different things. So you've got the same, this is the same study that we talked about with the p-values. This time you've got the green line. The green line is what you think before you did the study in terms of the probability of it's not before when you do the study thousands of times. This is the probability of the odds ratio you thought before you started. Minimally informative means that this is a wide bell curve because you really don't have a clue. If you're a little bit, you can use more informative priors, but they still are a curve based around the odds ratio of 1. The result, rather than now being a straight line, a point estimate at 0.66, the result is a probability distribution of where that result could have lay, where you think that the result lies as a result of the study. And the thing that you publish is neither what you started or the result you found. It's the red line, which is how far. So essentially the blue line pulls the green line across. You update your thinking from the green to the red by means of the blue. And so the result is the new knowledge. And this again is the probability distribution for where you think the effect lies. And you can see here they've predetermined in the gray bar what would be clinically relevant. And they've suggested now, for example, that you can see that this area in red is 50%, that there's a 50% probability of a clinically meaningful benefit in this study. And I think that's a much more useful than a p-value to give you an idea. You can see that this could be causing harm. Even in the blue, there's a possibility of harm. In the red, there's a possibility of harm, but there's a 50% probability of not only doing good, but something predetermined as clinically significant. So that's essentially how Bayesian statistics differs from frequentist statistics. So if we look at this again, I told you that it was minimally informative prior, so that green is quite a wide bell curve. And then they make these kind of strict rules in advance, because I told you there would be non-inferiority and superiority. There's also futility. So if a study is going on and we're not going to reach non-inferiority or superiority, then you need to know how to stop it. And we can come back to some of these, but it's essential. But let's just take the easiest one. Non-inferiority is that the probability of less than 1.2 is greater than 99%. And there is other probabilities than that, all in the sort of 99% or 1% realm. So you can see that in order to stop a study like this, you want to be pretty sure that you've reached either non-inferiority or superiority. So coming back to the question that the SNAP study is as asked, the first question is the most straightforward. Which is the best first-line antibiotic for MSSA? And as we've seen previously, nobody really knows what that is, or knew what it was before this study. Why does it matter? Well, there's this concept that, I said in America, people tend to use cefazolin, and in Europe and Australasia, they tend to use anti-staphylococcal penicillins. There's a theoretical reason for thinking that ASPs are superior. And that's a laboratory phenomenon known as the cefazolin inoculum effect. So MSSA, and importantly, this is why PSSA is separate, because PSSA don't produce these type A beta lactamases. So that's why PSSA was done separately. The MSSA that are penicillin resistant, some of them produce these type A beta lactamases, which can hydrolyze cefazolin. And while it looks, well on a plate, despite this enzyme being present, the isolate looks sensitive on a plate. If you use a higher inoculum, it starts to look resistant. And that's the graph on the right, where the MICs for cefazolin go up with a higher inoculum, but with the standard inoculum look sensitive. And that's why it's American Heart Association have recommended anti-staphylococcal penicillins for endocarditis and serious MSSA infections. What do the observational, this is observational studies leading up to this, what do the observational studies show? There have been quite a number of patients randomized, not randomized, observed, who were either put in a not randomized way, but in a chaotic way to cefazolin or anti-staphylococcal penicillin. And you can see that overall, it actually slightly favors cefazolin. The bigger studies tend to favor cefazolin, but there wasn't much in it. So the idea that the inoculum effect was important was not suggested by the observational data. But what did the randomized data show? So this study was, I'll explain why, was stopped about a bit less than a year ago. And here, like I said, it's an adaptive platform design. You can just look at single questions. You can just take out the data for single questions. And this is a single question in adults. I will discuss pediatrics. In the MSSA, but not PSSA arm, they were able to randomize 1,300 patients. So this was a large study at this point. 670 to cloxacillin or flucloxacillin versus cefazolin. And what did the results show? Well, here on the right, this is what they presented at ECMED, and isn't actually going to put this table in the final paper, which I think is a little bit disappointing. But because it's a log scale, the 0 is actually 1. So when we talked previously about no effect, the no effect line is here. Remember, this is not the result itself. This is where our new knowledge sits. So the result is over to the left, but our new knowledge sits here based on a not informative prior. And you can see that mortality, primary outcome mortality, was 17% versus 15%. So less mortality in cefazolin favors cefazolin, and the probability that cefazolin was non-inferior was 99%, because the non-inferiority margin was this 1.2 line here, and only the little 1% sits the wrong side of it. The probability of superiority, which was that the odds ratio was less than 1, which is the line here, that was 89%. So it's definitely non-inferior on mortality, and there's a good chance that it's superior on probability. But why did we not? I said that we would look for non-inferiority, and then if that was reached, we would look for superiority. Well, let's just do some secondary endpoints. So if you look at this again, this is very hard outcome mortality. You can see that the difference actually started to narrow towards 90 days, and you probably might expect that. If you made it 10 years, then mortality would probably be the same. But the probability of superiority at 28 days was 99%. And narrowed slightly as time went on. So definitely looks like you saved lives with cefazolin. Why was it stopped? It was actually stopped on the advice of the DSMB because of excess kidney injury in patients on cloxacillin, 19% versus 13%. And again, if you look at the graph, you can see that in terms of kidney injury, not only was cefazolin non-inferior, highly non-inferior, it was also very high probability of superiority. Nothing much in hepatotoxicity. So the key message was flucloxacillin is renotoxic. Cefazolin is not, so you should, just on those grounds alone, but cefazolin is also non-inferior and probably superior in terms of mortality outcomes. Everyone wants to know about subgroups. These trials, despite being massive, will never have, or unlikely at least, to have the power to detect differences in subgroups. That's not, it's just not possible. However, the key one people are interested in, the key two really, endocarditis and CNS infections. You can see third line down in endocarditis. This is mortality now. This is not the kidneys. Mortality in cefazolin was 15.4 compared to 23 in cloxacillin arm, with wide confidence intervals, but an odds ratio very much heading in the right direction. So it certainly seems that cefazolin is perfectly adequate for endocarditis. More definitive evidence than that is unlikely to ever come around. What about CNS infection? People worry about CNS penetration of cefazolin. There were 7 participants in the whole of SNAP. You can see how there will never be a randomized trial in CNS, even in this study, which is 80 sites across the world with thousands of patients. Only 7 had CNS infection. However, if you look at some narrative reviews on this, it does seem, and there are a number of people who have written about this, it does seem likely that cefazolin is both safe and effective in CNS infections. It might be that the dosing needs to go to 2 grams every 6 hours instead of every 8 hours. That's probably a sensible thing to do. But given that we know fluclox and clox are renotoxic, and it seems likely that cefazolin is the way to go, and there doesn't really seem to be any indication for anti-staphylococcal penicillins anymore. How are we doing for time? Okay, a bit short of time. So this is the PSSA. So this was stopped at the same time for the same reason. So this is penicillin versus cloxacillin in penicillin sensitive. It's much smaller, of course, because there were fewer patients, 125 versus 56. And the outcomes were broadly the same. The probability of non-inferiority was 96% and superiority 88%. This is for penicillin. So penicillin outperforms cloxacillin. And the kidney injury was exactly the same, 21% versus 10%. So it's not that one of these other drugs protect your kidneys, it's that cloxacillin is renotoxic. the next question that has already been answered is, should clindamycin be added to the backbone therapy? And this was, lots of patients were randomized to this. Anyone like to guess the answer? Not been published yet, but it is in the public domain. So I can tell you this was stopped on the advice of the DSMB for futility of superiority. So remember, when you're adding a drug like clindamycin, to get a meaningful result, you need to show that it's superior. And over 4,000, huge numbers of patients were randomized. And probably I had to look this up, what this means. Futility of superiority means that the probability, the odds ratio is less than 0.83 is actually what that means, is less than 1. So basically, the chance that you're going to show anything, a 17% improvement, which is considered clinically meaningful, is tiny. So you can imagine that actually the curve that we showed you is very close to 1 and very narrow. And so this has been stopped, which reminds me of one of my second favorite Einstein quote, that insanity is doing the same thing over and over again and expecting a different result. This is now about the 7th trial of adding a therapy, and continually we find that there's no improvement, there's certainly no synergy, and there's no additive effect, and just an increase in side effects. Just to show you the power of a study like this, these are all the sub-studies. On the left, these are actively recruiting, 11 studies actively recruiting, and then the 2 groups on the right, these are sub-studies that people have proposed and will likely go ahead. So the number of papers that will come out of the SNAP study at the end, if it ever ends, will be measured in the hundreds, probably the thousands. Because if you're a member of this group and you have a question, you can propose to add your question on, and you may only do it in your area. If you look on the left, some are only happening in Canada, only in the Netherlands. You don't have to get the whole world to join your study, but because of the way it's engineered, you can still get an answer to your question. Just an update where we are. So when I last looked, there were 4,900 patients, and it actually just ticked over to 5,000. So they're having their 10th interim analysis. A brief note on pediatrics. The reason I haven't focused on it, even though it's vitally important, is because nothing's been published in any form for pediatrics. It's all still remains randomized, and DSMB have seen it. The DSMB said there was no signal of renal toxicity in pediatrics, and I think it's pretty clear that renal toxicity that you see is kind of older people with frog kidneys, probably. There was no signal, and there was a long debate that pediatricians can weigh in about whether to also stop the pediatric backbone domain. The clindamycin arm has been stopped because it looked the same. That was no benefit, and they decided to carry on. So currently there are 219 patients in the platform, which, although small, is bigger than any pediatric Staph study ever done. And we're very much hoping that, well, we know that Rima Musa will be joining the study imminently, and Tigerberg Pediatrics are also going to be joining soon to increase the number of pediatric sites. And the backbone domains are all open. The oral switch domains are closed because of lack of recruitment. People were making the oral switch anyway in most of these kids. This is the kind of numbers and types of people that are involved. If you know any of these people, Josh Davis and Steve Tong from Australia, who set this all up, and then some high-powered people like Steve Webb from the Balance trial, and others around the world. Hundreds and hundreds of people. I think the number of what I just showed you is going to be published in the New England Journal for the MSSA part and in the Lancet for the PSSA part, with about 300 authors on each paper. So in the last few minutes, I'll just, the reason I didn't put this at the beginning is because we're unlikely to get this drug in the near future. The study was actually done, it's a head-to-head study done published in 2023, ceftobiprole, which I struggle to say, for complicated Staph bacteremia. This was ceftobiprole versus daptomycin, again, Vance Fowler. You could add aztreonam if you wanted to either arm, This is the Eradicate study. They managed to get nearly 400 SAB patients, which was pretty impressive, and they found non-inferiority. So ceftobiprole was non-inferior to daptomycin, and daptomycin was non-inferior to others. So it seems to be an option in Staph Bacteraemia and MRSA. To remind you, it's a 5th generation cephalosporin, as is ceftaroline. Ceftaroline is active against MRSA and staph, but is not licensed in Staph Bacteraemia, only in pneumonia and skin and soft tissue infections. But it is widely used off-label, I'm told, in salvage therapy, which are one of the sub-studies. I thought it was kind of interesting to see how they work. So when you get MRSA, if you look on the left, there's this where it says closed active site. The penicillin binding protein on the bacteria has a closed site there, and so your normal beta-lactam antibiotic can't get in and bind, and that's the mechanism of resistance, the PBP2A. Actually, the ceftobiprole actually is able to bind to that site, but ceftaroline works in a different way. It attaches in itself to this other site called the allosteric site, which leads to a conformational change. This is on the top row now, which opens up the active site, and then another molecule of the same antibiotic, ceftaroline, can then bind to the penicillin binding protein, and that's how it overcomes the mechanism of resistance. This could, and the bottom, it can also be done with something that wasn't the antibiotic in blue, can bind to this allosteric site, opening up the PBP for it to work, which I thought was quite interesting. Hot off the press, only published online on the 13th of August this year. It was dalbavancin for the treatment of Staph Bacteraemia, the DOTS trial. Dalbavancin is a long-acting intravenous lipoglycopeptide with once-weekly dosing, and you can see how people will be excited about once-weekly dosing. Particularly, well, we don't have outpatient antibiotic therapy here in the public sector. In places like America, they have a lot of resources go into outpatient IV therapy, nurses going around to people's houses giving IV therapy. And so if you could do that just once a week instead of twice a day or whatever, then that would be a huge advantage. It was done at 22 medical sites in the USA, 1 in Canada, and it was a slightly odd group. You had to have, it was complicated, so you had to have bacteremia that didn't clear in the first 72 hours, but did clear by 10 days. And there were an awful lot of people who were excluded from this trial because they didn't meet those criteria. You also couldn't have CNS infection, retained infected prostatic material, left-sided endocarditis, or severe immunocompromise. So you can see this is a very, narrow group of SAB patients. But they found they used the dalbavancin was just on day 1 and day 8. This is when the patient's already culture converted now and has had sort of 10 days of IV therapy or conventional therapy. And they used, and I probably won't have time to go into this, a desirability of outcome ranking as their primary outcome. So I think these are kind of interesting. It's not the sort of football team, it's 1-0 or it's 1-1. It's something a bit more complicated at day 70. And I'm going to just skip on because I wanted to discuss these because they're becoming more and more useful. But what they use, if you look at a desirability of outcome ranking, basically ranks people with a list of things that good outcomes to bad outcomes, and it's much more representative. You can basically represent harms and benefits in a single measure and include things like quality of life in your primary outcome. At the bottom there, you can see that they came up with and validated a door for this, specifically for this trial, involving clinical success, infectious complications, safety complications, and mortality, and also health-related quality of life as a tiebreaker. And you can kind of see on the results how this worked out. If you look at the top, in dalbavancin versus standard therapy, they both, there was 100 patients in each group, making percentages quite easy. 49 in both groups were alive with no events at 70 days. Then if you can see, standard therapy did slightly better, alive with 1 event, 37 versus 34. But otherwise, the rankings were very similar, the way people scored. And when you look at this on a forest plot, you can see that the desirability of outcome ranking probability for superiority of dalbavancin, or the probability of a better outcome with dalbavancin was 47%. They said that it would be superior if the 95% confidence interval, this 39.8, was greater than 50. So if this line here was moved across that way, so that this was side of 50. So they said the dalbavancin was not superior based on their a priori statistics, but they did think it was non-inferior with clinical efficacy of 73% in both groups, similar numbers of adverse events. So dalbavancin does seem to be an option in this narrow group. The Staph score, I would like to mention because I think could be important. I'd be interested if there are any comments from microbiology. So I won't bore you with which of these is which, but one of these is Staph aureus and one of them is coagulase negative staph. And the problem is we have in a high resource country, these results will be phoned out at the point that the gram stain is positive to the clinician to consider Staph aureus, but we have so many coagulase negative staph contaminants that that's impractical. And you have to wait another 24 hours, delaying, one of the reasons for this mortality is probably delayed definitive therapy. And so you have to wait another 24 hours for growth on a plate to see which it is. So these resourceful people in Japan came up with a score to see if you could tell the difference on a gram stain, and they wanted it to make the acronym STAPH. So they used size of, these are the words: size of the clusters, time to positivity, aerobic enlargement, pint. I don't know where this comes from, but it's essentially means, do the clusters look three-dimensional, and hemorrhage. And just to show you this, A and B are Staph aureus, and C is coagulase negative staph. You can kind of get the idea that the size of the clusters are different, that that you can't focus so well on A and B, so they're 3D, where you can focus on C, so not 3D. B is actually anaerobic, which we don't have, but the cocci are smaller in the B anaerobic than A aerobic bottle. And then going down to D and E, you can see this area which they call hemorrhage. It's not actually hemorrhage, but clot underneath, sort of appearing to be underneath the clusters. And F, that is clot, but it's not part of the cluster. So that's coagulase negative staph. And so they came out with this 5-point scale, and it seemed to do really well, I thought. They focused on the cutoff value of 3, which is like the least helpful, actually. But if the score was 0, 1, or 2, there was a 100% probability it was a coagulase negative staph. And if it was 4 or 5, it was a 100% probability it was Staph aureus. So I thought this was an interesting potential advance that might be available in our setting to determine at gram stain whether we were dealing with a Staph aureus or not. Very last thing is phages. There's a phage sub-study in SNAP. A phage is a virus. Bacteriophage is a virus that parasitizes bacteria. You can see where it joins with its tail fibers and spikes, injects its nucleic acid, which replicates in the cell, and then the cell dies. So this seems like this is actually not, it has actually been quite widely used in some parts of the world without very good definitive data. Could it work in staph, or how does it work? It targets a specific bacterial species, which is great. So you would just target Staph aureus and nothing else. It's very effective against biofilms, which sounds good. And it's self-amplifying. So essentially it multiplies, feeding off the Staph aureus, parasitizing the Staph aureus basically, and multiplies itself. And then my assumption is that it dies when there's no Staph aureus left. There was a phase 1b/2a study published earlier this year. They used patients with complicated SAB, and they added this phage APSA02 or placebo to best available antibiotics. It's dosed every 6 hours for 5 days, but it was very well tolerated, and it had a higher clinical response, and it seemed to prevent relapses. So this is a possible future arm. Can anyone guess from the share price which day they published it? Yeah, very beginning of June. So their share price did very well. So phages could be the way to go, and I'll leave you with an irrelevant but my probably favorite Einstein quote. Thanks very much.
Cool, great. Thank you so much, Tom. It's really nice overview, and it's lovely to see a lot of movement in the field at last. And I think it's, it's part of also the, as you say, broader movement towards these kind of platform trials and taking some of the initiative back to the clinicians, I guess, for rather than these big pharma trials with one new drug. Um, uh, I guess the one, because we more or less out of time, but I just wanted to ask the one question which I think often comes up is how to relate these Staph aureus results to the vexing question of endocarditis, because obviously you've got different trials saying different things. So for example, in the POET trial, most people were on two agents if they've moved to oral. I think most people feel that's probably overkill. And do you think this will be enough to convince the cardiologists with this trial?
Well, only if they, what I seem to find is that cardiologists say that we can't use oral because there's no evidence, and then we present them with the trial, and they don't want to be in it. I find that quite frustrating. Like we will only answer this question if we put people in it. I think there's absolutely equipoise for single agents. We've seen over and over that multiple agents are ineffective. There is a rifampicin trial going on for prosthetic material if people are interested as part of SNAP. So, rifampicin adjunctive in that setting may be beneficial. But I think there's ample evidence, in my view, to think that oral therapy in patients who have improved, culture converted, based on what we know from Staph and what we know from the POET trial, I think there's ample evidence to think that we have equipoise and that we should be randomizing these patients. And that's the only way we'll get to the answer, in my opinion.
Yeah. And I mean, this is the opportunity, right? As you said, you're not going to get another Staph aureus trial this big.
You'll never get a trial like this again. It's there to be, the subgroups will be analyzed as we've seen. Cefazolin does seem to be preferable, even despite the cefazolin. Obviously, they're looking at the isolates and they'll do studies on them to see if there are any subgroups, but it does seem that that works. And everything we know about antibiotics is that it doesn't matter how they get there, it just matters that they get there to the bug. So in my view, I think we should be randomizing these people actively, yeah.
Great. And then lastly, I just see Professor Moose has put in the chat about clindamycin and Staph toxic shock syndrome. Were any toxic shock syndromes enrolled in SNAP?
No, but there was no benefit in children.
Okay.
We are doing a study in strep. Again, this is the thing about these trials. You can then the same people, get to know each other and get to work well. And now they're doing strep, where they will test that. I will predict right now that it will be of no value whatsoever. But that's just a prediction. But there was no benefit in children of clindamycin, no. Some of which would have had toxic shock, I think.
Yeah, and sorry, I keep saying last thing, but I keep getting great questions in the chat. Someone's asked about if you have a persistent bacteremia despite source control, is there any evidence that they could use as guidance?
Well, it's not yet, but it's one of those studies I showed you is ongoing. In my view, my reading of the observational evidence, adding a second beta-lactam like ertapenem it seems to work, but that is being actively studied in one of those sub-studies. So yeah, and I'm reading between the lines. You might know more about what happens in America, but it seems that they commonly use dual therapy out of maybe desperation for these folk. So yeah, I think a second agent is probably the way to go. But again, we would like to potentially enter that study so we could put our patients into it. And maybe the last thing for me is that everyone wants to join the SNAP study and contribute data, then they're more than welcome. They just have to find the funding. That's the problem. That's the issue with a study like this. It would be great if, some funder gave $100 million to do this study, but unfortunately it's been all different people around the world getting small little pots of money. But if anyone can get money and wants to contribute to this, they can. They just have to contact me.